All right, welcome to Researching Happy. This is episode 36 with Dr. Matthew Iasiello, and a couple of updates before we get into the episode. Researchinghappy.com is now live. You can go and check that out. You find all the old episodes that are there, but also there's an opportunity to join what I'm calling the Journal Club. And so I'm going for something, if you haven't heard about it yet, in the previous episode, I'm trying something new to try and bring a little bit more structure to the episodes, where it'll still have all the stuff we've been doing, having these conversations with experts in the field of happiness and well-being and mental health, but talking specifically around one of their recent papers. So in this way, we'll be a little bit tighter with the conversation that we're having. It'll be easier for people to sort of follow along and keep up to date with the latest evidence and thought that's out there. So this episode is not one of those, just because of the way that it's timed, although we do talk a lot about particular papers of the guests. So I'll link to those. And by joining the Journal Club, what I'm hoping is that we can build this community of people who stay close to the evidence, people who are passionate about wellbeing prevention and promotion. And basically, I'll give you the heads up of who's coming on the show and the papers that we'll be talking about, so that you can have a read of the paper and submit any questions that you might have for the guest, either about the paper or just about the work that they do. So in this way, giving you a little bit more connection with the guests as well. So today we have a giant, basically, I would say, in the field of mental health research in Australia and around the world. It's Professor Tony Jorm. I don't think he would describe himself that way. He comes across as a very humble man. So humble that he's actually retired and continues to work off of his own superannuation, rather than taking up the position that a more junior researcher could have. As you'll hear, we probably hope that there are some others, maybe even researchers older than he, who might want to follow his footsteps, but obviously that's up to them. But I thought it was a nice model. And we talk about Tony's impressive career, basically, the huge impact that he's had through mental health first aid, what the world looked like kind of before his impact, the work that he's had, and how it's come along so far in the last 20, 25, 30 years. So, yeah, enjoy the episode. Let me know what you think. Go and check out the website. I'm always open to feedback. Signing up, you'll hear from me, and not too often, obviously. I don't want to bug anybody. I'm just sending updates on who's next on the show. But yeah, I want to stay really close to the community and really open to being contacted and hearing from you. So thank you. Enjoy the episode, and yeah, have a great day. Okay, so welcome. This is Researching Happy, and we've got Professor Emeritus Tony Jorm with us today. Welcome, Tony.
Hello.
I never know whether professors that are emeritus want to be referenced as emeritus or still professor, or do you go back to Tony?
I always went by Tony. It's only in formal situations I ever use the title. I never use it in personal life at all. But although emeritus means I'm retired, I'm not actually retired. I'm officially retired. So I do actually work full time as a researcher, but I do it as a voluntary basis.
Oh, wow.
And the reason I did that is because I was very fortunate for about over 20 years, 30 years, I think it was. I had National Health and Medical Research Council fellowships. So they're grants that pay your salary, but you have to compete in open competition every 4 years. And I was terribly lucky, I kept getting them. And then I got to a stage where I was due to reapply, and I work with a lot of young researchers, and they're desperate to get those salaries. And I thought, oh, I've got a lot of superannuation. I really don't need to compete with them. I can just live fine on my superannuation and do what I want to do anyway. So I just continued on and leave it to the young to compete for the salaries. And actually, I have a more secure income now than I ever did as a researcher, because I don't have to compete with anyone anymore. I've got it till the day I die. Yeah.
I probably shouldn't be laughing at that, considering I'm probably in that boat, actually. But That's extremely generous of you. I mean, there wouldn't be that many who would have made that decision.
Well, it actually, I have to say, it disappoints me. There are people older than me who are in the competition for NHMRC salaries, and I think they would have enough superannuation income to not need it. Why are they doing it? The other thing is now with these fellowships, they're now called investigator grants. You can get them without salary, and that's what I have. I actually have an investigator grant, but I don't have a salary with it, so I can employ other people on it.
Okay.
But it's always been tough to get these, but the success rate's been going down and down and down for decades, and it's tougher than ever. So, I've had a good run, give somebody else. I think it's like returning to a tradition because, in the 19th century, early 20th century, there were men of means. I use the word men deliberately because only males ever did this. Who, if they had an independent income, they could live it up, or they could devote themselves to science or the arts or philanthropy or something like that. So I see it as a bit like that tradition. I've got an independent income. I can live fine, so I'm devoting myself to science and other things as well.
Yeah, fantastic. There you go. I actually had no idea of that, so I'm glad we've somehow covered that off really nicely. So
it's relevant to well-being and happiness, isn't it?
Yeah, absolutely, especially for the people who actually want a grant.
Yeah, it is absolutely. Yeah, it's a big stressor on people. Yeah.
Yeah, it is. It is. It's huge, and yeah, I don't mean to. Yeah, like I say, I guess I'm in that category, but I'd love to have a bit of a bird's eye view just of your career. You've got such a storied impact in this space, and so I was really fortunate to see you presenting a couple of months ago at a conference in Melbourne, and I thought you did an incredible job just giving a very, very brief landscape of sort of prevention, and that will be probably the theme of today. But it'd be great to hear sort of how you started and how you've ended up where you are today.
Well, things have gone through various phases, I guess. I studied psychology as an undergraduate, and after I did honours, I then did a master's in clinical psychology. And at that stage in Australia, there were only 2 master's courses in clinical psychology. There were no doctoral courses. And I went from Queensland, where I was an undergraduate, because they didn't have any clinical training at that level, to the University of New South Wales. So it was all very new. And I think that was only I was in the 3rd year cohort that actually went into one of those masters. Wow. Anyway, when I completed that, I worked in the New South Wales prison system for a year. And a year was quite enough, cured me of wanting to do that. It's a pretty stressful job. And I went back and did a PhD, and I did it on dyslexia. And following that, I got a job as a lecturer in the School of Education at Deakin University. And after doing that for some years, doing undergraduate teaching, I ran the Intro to Psych course and things like that. I then got a job at the Australian National University on an NHMRC funded unit, and then that got me in through the NHMRC fellowship system. So I hadn't really worked directly in mental health research at that point. So I started working with a guy called Scott Henderson, who's a psychiatrist, and he was my boss. And he was interested in, the mental health of populations, basically. And a lot of what clinicians do, like what I trained in clinical psychology and what he would have done in psychiatry, it's all about individuals. Like, how do you get an individual to have a, function well in life, to be, free of symptoms and so on. But it's not thinking about how you get the whole population to do. And that was a sort of very different perspective. And I think that's what set me on that path of thinking about, well, how do you get a mentally healthy nation? So I did that with him. So we looked at how you can reduce the prevalence of depression in older people and dementia and things like that. Anyway, then in the when a change occurred would have been in the mid 1990s. Mm-hmm. So what was happening in Australia then is the big old psychiatric hospitals had virtually disappeared. Inpatient mental health care had gone into hospitals, and really the emphasis was the only people that really didn't know about mental health problems were professionals. It was all about what they knew and what they did. That's where the action was. And then in the mid-90s, there was a bit of an emphasis in Australia about empowering GPs and saying, well, you know, they need to know because they're at the front line. So a lot on GP education. Anyway, that made me think about, well, it's not just about GPs. Like, everybody needs to know, because the prevalence is so high that we're all either going to be affected, or someone in our family or our workplace or our social network is going to be affected. So we all need to have some level of knowledge across the whole society. So together with colleagues, we had a discussion about this, and we created this buzzword, mental health literacy, which is nothing profound in it. It's just like, if you want to draw attention to a gap, you give the gap a label. So mental health literacy was just a label for that gap. And we never really expected it would catch on beyond researchers, but it's sort of gone out with the general public. You hear it all the time. It's gone sort of international.
Absolutely, yeah. Absolutely.
So what we did was to start off in the area, we managed to get just scrape together some funding. It was just by chance we managed to do it, to do this national survey of the Australian public, a representative survey on their understanding of mental health problems and what should be done about them. And then we did surveys with a whole lot of professionals, like we did GPs, psychiatrists, clinical psychologists, and eventually mental health nurses. We got very good samples. And what we found was this huge gap between the way the professionals thought about it. They showed a lot of agreement in the way they thought about it, despite the different training, and what the public thought. So then you think, okay, you know, you could say, all right, we've got all these treatments, interventions, you know, we've got evidence on these, but if the public don't believe in those, don't want those, or don't know about those, it's not going to work. So you've got to work at their end as well. So also I was influenced by people I knew at that time too, because I knew people. I remember I had a neighbour who fell off a roof and hit his head, and he developed pretty bad depression, and he wasn't an educated man, and I think how he and his family, they were very disadvantaged by that, you know. And I knew other people who really knew a lot about it, and they knew their way around the system and how they got a good deal out of that. So there were those sort of personal experiences as well. So then I began thinking, well, how can you reduce this gap between public and professional perceptions of things? And, you know, what sort of interventions can you do? So over the years, I went through quite a few different possibilities or interventions and tested them out. The one that went most successfully has been mental health first aid training, which has really gone very big. And that started because my wife, Betty Kitchener, and I had a conversation when we were walking our dog one evening. We lived in Canberra then. And we just had a conversation. I'd been to this planning meeting with the Commonwealth Department of Health for a national action plan on depression. And someone there said, oh, what we need is depression first aid. And I thought, oh, that's a really interesting notion. And my wife, Betty, has a history of recurrent depression starting from adolescence. And, you know, in adolescence, she had this initial episode and she had a suicide attempt. It was really handled very badly by people around her. And she used to teach at that time Red Cross first aid on the side.
Really?
Used to do it. So we thought, well, why don't people like Red Cross teach people what to do? Because, you know, how often do you ever need CPR, you know? But, you know, the chance you'll come across someone who's having a panic attack or suicide or something is probably much greater, but it's not covered. So, you know, we both got very excited about it, and we thought, oh, right, this is a potential way of, you know, one method of plugging the gap. And we decided that we would develop a mental health first aid course. We never thought of it as a very big operation. We thought it would be something we would do as a community service activity in Canberra where we lived. We thought a couple of courses a year on the weekend. That was it. So we talked about it for a few years, and we used to come up with ideas about what to do, but we both had, you know, jobs and kids and so on, so we were busy. And then in the year 2000, then it really changed, and Betty decided, I think, to bite the bullet on it, and she reduced her paid working hours, which is at Canberra Hospital, and she worked one day a week as a volunteer on it, and that really got it going then. It really got it going, and within a year, you know, we'd got a small grant that paid a part salary, and we had a curriculum, and she piloted it and so on, and you know, because I was a researcher, we started doing evaluations on it, and then we moved into randomized control trials. And then it just got bigger and bigger and bigger. And it obviously just fulfilled a need at the time. And she's an exceptional teacher, and she put an enormous amount of hard work into it to disseminating it. So it went from Canberra into rural New South Wales to interstate, and then once we got the first data published, it then started going international. So now it's up to, I think it's 7 million people trained. We've got a couple of courses in Canberra on the weekend. Now it's 7 million, and it's very close to 30 countries. I forget how many it is. Very close to 30 now. So it just keeps growing and growing. So we sort of not realised how big it would get, but yeah. So that was sort of a major way to try and upskill the population. But we did other things too, like I worked with Beyond Blue to develop consumer guides, which I know you've done some related work on that, to try convey the evidence to the public, and hundreds of thousands of people have read those sort of guides. We've done promotion of self-help strategies. I've worked with people like Marie Yap, particularly at Monash University, for many years on how to upskill parents, like preventive parenting. What would you do as a parent to reduce your child's risk of developing anxiety problems, depression, or substance use problems? Mm-hmm. So thinking about all these areas where the community can be empowered particularly for prevention and early intervention, mm-hmm. would be the end of the spectrum where we particularly want to empower the public. So I've rambled a bit there, so you can ask me now.
No, that's no rambling there at all. The parenting, that wasn't the Triple P program, was it?
No, that's from Matt Sanders.
Okay.
No, this is called Partners in Parenting. So what we did is we did this analysis of longitudinal studies looking at what things parents do predict a better outcome for their children's mental health. Interesting. And then we did and what it tells you things is, it gives you very general things, like it says, where the parent shows a lot of warmth, that's good. We said, well, how do you be warm? What exactly do you do? So once we found out these sort of general, scales that predict, then we did this Delphi study. So what we did was we then went through all these sources, mainly websites, advice for parenting. We extracted all the actual behaviours you do.
Yes.
Like how do you show affection or warmth to a child? What do you actually do? And then we gave them to expert panelists and asked them to say which were the critical things. So then we ended up with these guidelines which actually show you action behaviour to do, that fills out what these scales are telling you. And then we developed online interventions around those to sort of train the parents and look at then what happens with their kids as a result. Awesome. So that's another area of sort of building the capacity of the general community.
Yeah, all right. I want to get onto parenting in a second, actually, but I've got kids running around the backyard right now, so you'll probably hear them in the background. But in terms, so that 2000 was when mental health first aid sort of kicked off. You've got, so it's 24 years down the track. What do you see as the successes of mental health first aid in that time?
Well, it's big success, I think, has been as a dissemination model. Yeah. And many people, like academics, they develop interventions and they do some evaluation that gets published and think, oh, well, nobody's taking it. There's no mechanism, to fund it, continue to disseminate it. It's very hard. And a lot of them just go by the wayside, or they go on a small scale. So we felt with the first aid model, which had been around for a century, the public knew about that. Like the idea that you should know how to do CPR or know what to do if someone was bitten by a snake or might have a broken leg or something. People got that. And people were prepared to pay. So, you could go through your workplace or something, or just as a good citizen, and you would pay to do it first. So there was a cultural model there that we could slot into. So then we could say, okay, by analogy, you are going to have contact with somebody who has these sort of problems. Would you know what to do? Would your employer pay? Is it part of your work role because you work in some human services occupation? Or do you have somebody close to you that's affected and you want to know? So I think having that model really helped a lot. Mm-hmm. And I think there's been a big change in my lifetime in openness about all of this, and mental first aid is just one many components that have gone on, but it's absolutely phenomenal. Like, I'm 73. If I look back when I was 23, no one ever talked about these things. No way. And people are very reluctant to get any professional help. There's very little help available anyway. People just suffered in silence and you shut up about it. But now the openness and the degree of knowledge that people have is just hard to imagine the change that's occurred in that time.
Yeah, you told that beautiful anecdote about, I think it was like a minister for gambling or minister for horse racing or something.
Oh, yes, that's right. I grew up in Queensland, and they always used to have the minister for racing. And in fact, I think nearly all the states used to have the minister for racing. And I remember when we had one, it was the state election. I forget which state I lived in then, and one of the major political parties said, if we get elected, we're going to have a minister for mental health. And then the other party said, oh, we will too. I thought, right, mental health is as important as racing. That's good. And now it is. They've all got ministers for mental health. So it's made it, Yeah,
and it's those are the sorts of, that kind of zoomed out perspective. You probably do see maybe more of the wins than the people who are sort of on the ground just thinking about how the system could be and what, I kind of find myself feeling a bit like that sometimes, like getting frustrated with what could be and what's not happening. But actually huge strides have happened, even like you say in the last 20 years.
They have. And you've got to have perspective on that, because you can look at a period of a few years and you think, there's some 2 steps forward, 1 step back. But then you look over decades or you look over a century and it's just massive change has gone on. They're really big, very big gains that have gone on in society for the good in a whole lot of ways. Although negatives arise, overwhelmingly things are better. And, the advances in physical health, have just been absolutely amazing. And we haven't seen the similar sorts of advances in mental health, but it is possible, I believe, to improve the mental health of a whole population.
Yeah. And I mean, the last thing I wanted to ask on mental health first aid was really probably on how does it, I know researchers, we like RCTs, we like controlled environments.
Yes.
You've put, in a way, I would say courageously, mental health first aid out into the community, which means you have you have some control over it, but it's really out there now. Have there been challenges with that?
Well, they have one of the other aspects of that model that have been successful is that we went for a devolved model. So we could have said, we're in control, we're the head office, we do everything. But to really make something succeed, you've got to have it embedded in local communities and local cultures. So with mental health first aid, you can go to any country town in Australia and you find there's an instructor there. Or you go into some sort of human services industry and there's an instructor. So like, if you want to train the police or prison officers or something, you need someone who's one of them, to go in and do it. Yeah. Somebody's embedded. And I've done a bit of work with the guy who's Nepalese in Australia, and he does mental first aid training with the Nepalese Australians. And I don't think anyone else could do what he did because he is part of that community. He's got that embeddedness. Similarly, with Aboriginal mental health first aid, it's very important to have Aboriginal instructors going out, teaching Aboriginal people. Mm-hmm. And there are challenges in doing all of that because you're giving away some degree of control of the whole thing, but there are huge advantages as well. And certainly when it goes to another country, it's better to work with an organisation there that knows their local system and culture and work with them to develop an adaptation that's suitable for their nation and subgroups within their nation rather than try and do it all centrally.
Yeah. And so I've got a question that I hope takes us from this sort of conversation to the next part of the question, which is really to talk about sort of the future of what you think, the future of mental health prevention looks like. But the way I'd like to sort of bridge our conversation is, I really appreciated an article that you wrote about the challenge of evaluating preventive programs, complex programs with lots of downstream. And so obviously there's a bit of background, which is sort of a traditional randomized controlled trial, systematic review of RCTs sort of didn't look that favorably upon mental health first aid. But I think you rightly have challenged some of those results in the sense that these are complex things that we're talking about with multiple downstream multiple downstream benefits that are very hard to capture. So
Yeah.
I wonder if you'd like to go into that a little bit. Like, what are
Yeah, I
the
would.
outcomes?
Yeah, Matt. Yeah, absolutely. Yeah, what you're referring to is a review of the Cochrane collaboration. So for anyone that doesn't know, the Cochrane collaboration is sort of an international organisation that does reviews mainly of randomised controlled trials, and they're famously famous for saying that there's not enough evidence to support anything. And some people have parodied this. They said, looking at parachutes, there's no randomised controlled trials on parachutes. So we don't have enough evidence to know what parachutes work. So there have been parodies of all that. But randomised controlled trials originally, they were for drugs and medical interventions, and they have an application there. But when you get into things that involve downstream effects, it gets very hard. So there have been a lot of randomised controlled trials on mental health first aid. But what you do, the participant is the mental health first aider. So you train them and you can follow them up. But then they go and they interact with other people in their lives. And those people are not participants. They're not easy to get hold of, ethically or practically. So you can get what the first aider says happened, and they say, oh, this good things happen. But then people say, well, was there a benefit to the mental health of that person? They're really hard to get. So the Cochrane collaboration did a review of mental health first aid trials, and they said, well, there isn't any hard evidence that mental health improves for the person who's the recipient, which is absolutely true. Not for want of trying to do that, but it's extremely difficult. And there are a lot of psychosocial interventions where that's the case. So anyway, I wrote an editorial saying, what if there was a Cochrane review of the Cochrane collaboration? So the Cochrane collaboration, if you go to their website, they have a slogan. I'm challenged to remember exactly what it is, but it basically says, review the evidence, change practice, improve health. It's got like 3 steps.
Oh, I've got it here.
You publish the Cochrane review, then some practitioners look at that and say, oh, okay, that's what works, I'll do that, and then there's improved health. So I went and looked at the Cochrane has a database of randomised controlled trials, and I looked for all the ones. I've seen them all on the Cochrane collaboration. There is not the slightest evidence that the Cochrane collaboration improves health. But I don't think that means it's not worthwhile. It's just you're not going to get that in a trial. It's a complex thing. So somebody does the review and they publish that, and then you think, okay, then has somebody put it into clinical practice guidelines? Have people accessed it on the website? Have the practitioners then changed what they did? Did their patients then change what they did? And then was there health benefits? So you've got all these steps along the way, which you cannot get from this one design of the randomised controlled trial.
Exactly.
So I did a search of how many studies are published on mental health first aid, and it's hundreds. But the number of trials is much, much smaller than that. So they basically wipe out any evidence that isn't a randomised controlled trial. So it's taking a drug intervention, drug treatment model and trying to apply it to things which are much more complex than that, and it's just not the right design. It has its place. And I think when you get into prevention, I'd call mental health first aid early intervention more than prevention, but when you get into preventive interventions, it's very much like that. It's they're usually much more complex to evaluate and not easy to do in a tight trial.
Exactly. And look, because like I was just laughing in my head thinking of the headline of like Tony Jorm leads the lawsuit to get Cochrane to remove the phrase better health for lack of asking.
Oh yeah, because you don't have any evidence. To support it. Yeah, I know. False advertising.
Yeah,
it's false advertising. That's for sure. Yeah,
but it's a hard one because I think there's at least an audience who would say what Cochrane says goes basically, and so there's the potential that it undermines health if it's unfairly coming up with conclusions like the ones that you're basically contesting. So
yeah, the other thing is, sorry, Matt, you go ahead.
No, please.
I think the other thing I've realised, thinking about mental health of populations too, that often the changes that you see are very long term, like over 50 years or something like that. And sometimes they're only visible historically. Like if you look at like in the 20th century, there were big changes in the height of people and there are big changes in intelligence test scores. But if anyone ever did a randomized control trial, with a group of children or something, and then looked at the effects, on height, it might find nothing. But you look at it and you think, this is massive change. It must be due to some change in the environment. It can't be, not likely to be due to genetic selection. But you'd never see it in a trial, but it is there. And I think often we're dealing with things of that sort.
Yeah, and that's exactly where I wanted to go. I guess now is I had this conversation with some philanthropic funders who have supported us, and they were doing a bit of work on the ground just to see, what they wanted to hear from people around what were the challenges that they thought were associated with trying to work in this space of prevention and mental health, and one of the challenges that I raised with them, I thought, was the absence of any models. Like research methodology, that we could be relying on to demonstrate the impact of our work. And that's hard for researchers, I think, as we've said, because like you're saying, you need long-term follow-ups and you're only talking with small sample sizes where you would expect to see a change. So that sort of statistically has problems. It's hard for researchers. It's almost impossible for community groups. And I wonder if you have any, if you've seen much in that space, like any, it's almost like the threshold for evidence. We're held to the threshold of what a pharmaceutical company could easily test in cells or in drugs. That's easy in a sense because they can do huge sample sizes. Have you seen much in the way of sort of lowering the threshold? Sounds wrong because it sounds like, lowering the quality, but there's like variety in the types of data that would be evidence.
You need a broader range of methodologies. The randomized control trials are beautiful things for inferring causation, but they have limitations in other respects. And even when we do randomized control trials, one of the big problems is you can't maintain people indefinitely in control groups.
Yes,
so often with like psychosocial interventions, you put them on a wait list and then you give it, and you might think, well, what about 5 years' time? And even with medications, like you look at things like antidepressants, which have a lot of randomized control trials, but nobody will ever keep people on placebo for 5 or 10 years. But people do keep on antidepressants for decades, but nobody knows what because you can't do it. So you've got to look at other types of evidence. But I think, we could do more trials of a very different sort. So, there was a guy called Campbell, a very famous researcher, who wrote this paper in the 1960s, I think it was, Reforms as Experiments. And it was about whenever we do any social reform, we should treat it as an experiment and evaluate it. And we don't do that. So often, like in Australia, the government they work within the political time frame of when they're elected, how many years they're elected. So they say, we're going to do this, and they implement it. And then they get KPMG or some other group to come in and do a post hoc evaluation, which usually isn't very clear. And that's it. It's very hard to go backwards. The idea that you'd actually try it out first in a rigorous way and then decide whether you're going to implement it isn't something that we've done. And I was very impressed with this experiment they did in Finland, the Finnish basic income experiment. So they did by legislation, the Finnish parliament legislated for unemployed people to either get the standard unemployment welfare or to be on a random basis assigned to a basic income. So the difference is, you go on the standard welfare and you've got to go and show, well, I'm looking for work and I'm doing this and have you found a job yet and all this. They're dealing with the bureaucracy. They said, well, we're giving you so many euros a month and that's it, you go and work things out. And they were interested in the impact of this randomization on unemployment. It had no effect at all. But they put in some well-being measures and some that are really getting to mental ill health as well. And it had effects, So I think, wow, why don't we do that? Could a basic income really improve mental health? We should be doing those sort of things a lot more, I think, as a nation, have a more experimental society. But these are things like academics like you and I cannot do that. We don't have the power. We need to have people in Parliament who think this way.
And I see that everywhere. I was thinking about it. I don't know if you're a footy fan or not, but
No, I'm not. I know nothing about footy.
No stress.
So go on, you tell the story.
That's okay. So I'm a Crows fan in Adelaide, and they're terrible. And, they had, they've lost against the bottom team, and now it's too many games in a row, and sacked the coach. And it's like, you have no idea, as a fan or even as a media person, you have no idea what the problem is in a footy club, right? And that's pretty complicated. It's nothing like, population mental health. But you've just assumed it's, that's where the problem is. We're just going to get rid of the coach and some new coach will come in. And it's like, anyone who's ever evaluated, I think the sort of the Freakonomics guys do stuff like this. They look at how do teams go once coaches get sacked. It never works. Or it only works 10% of the time. And so that idea of like, we're just going to go with a policy, we're pretty sure we've got it right. Or we're more like, it's pretty sure it'll win us votes. That kind of myopic vision on solutions is just almost a detriment across society.
I know. And people only want to hear the answer, we did the right decision in the end, don't they? But as a researcher, you always got to be open that this is the wrong decision. I might truly believe in this, but it might do nothing and it might do harm. And we're always got to be open that it's either useless or harmful, as much as we might be committed to it. Absolutely.
Do you I was thinking, because you brought that up in the conference, and I was thinking of that with the mobile phones in schools, because now schools, there's, and I think this is something I'd like to go into with some of this prevention work, because there's a confusion between, like you said, about parachutes, what is kind of good, quote unquote good, and what is evidence-based. And I think there's this sometimes an unwritten assumption that it's good if it's evidence-based. And, your parachute example is a perfect one, which is a parachute is good with or without some RCTs. And so, some schools have decided to just kick out phones. I don't have a problem with that personally, but some schools have done it and some schools haven't. So is there someone in Australia evaluating the impact, just like you say?
Yeah, very good question. It's exactly the sort of situation you'd want to do it. It's a sort of a natural experiment. It's not randomized, but it's quasi-experimental. And there's a natural control group there, and it's absolutely ideal. But if only somebody got the funding and they got the researcher to get in there before they implemented their policy and compare those different schools, we might get an answer to that very difficult question. Because there's no way you and I could say, put in for a grant, we want to randomise people to get rid of their phones or not at school. Because we have no control over it. Just like we have no control over government policy, but we do know how to evaluate it if we could work with them.
Exactly. And I was at a conference a little while ago, and Tim Lomas, who's in London now, he's at Harvard. He said something like, researchers, we have to put in an ethics application to minorly change the lives of 50 people. And yet, and that'll take us months and costs whatever. And then with the stroke of a pen, a politician can come and change everybody's life for better or worse with no consideration. So it is. I think researchers are the only group that I know that have to get ethics real ahead of everything they do, absolutely everything. And for those who are listening who are not researchers, you have no idea how much detail and work goes into all of that. I'm working on one right now, and it's, this will be nothing to you, Tony, but who will you contact? How will you contact them? What will you tell them? What information will you give them? What right will you give them to reject your, what will their, anyway, the list goes on. So going back then to mental health prevention, even if we just talk Australia, what do you see? What do you think are the levers we can be pulling? Because there is this sense, I guess, that we've thrown a lot at mental health in the country. It doesn't feel like a lot's changing. It sometimes feels like it's getting worse, despite all the effort and funding. Where do you look for some sort of solutions?
Well, just to comment on that, it is not getting better. I mean, I've done analyses on this over time. Look, the Australian Bureau of Statistics measures mental ill health every few years through the National Health Survey. We've had it for over 20 years. You can plot it, and then you can look at the number of mental health services people get in the population, the amount of expenditure, and it's pretty well flat, despite a huge increase in expenditure. So just spending more on services itself is not, unfortunately, not the solution. Which is not to say there aren't individuals who benefit from it, because I believe there are, but to improve a population, it's not, doesn't seem to be the strategy.
And I meant to say worse as well if I said better, but thank you for that.
Yeah, and for some group, like you were talking about mobile phones, well, for young people, if anything, the trend is to get worse. And we've had huge expenditure on youth mental health, absolutely huge on services through Headspace and other things. And in that time, which is not to say there's anything bad about what they're doing or anything, it's just there are obviously other big drivers of mental health problems that they're not addressing that we've got to address. So yeah, we do need to get on this preventative approach. One other thing that I think is positive that's occurred recently in Australia is that the Australian Treasury has pushed this idea of a well-being budget and a well-being framework, and a number of countries are doing this now. So they're saying, well, why do we have an economy? You know, what's it all about? What are governments all about? When you get down to it, they're all about making our lives better, you know, which is making us happy, improving well-being, and decreasing mental health problems, ill-being. You know, it's those two things. And so, you know, should we be saying across all areas of government activity, well, does it do this? Are we better off? Are we having better lives as a result of what they're doing? So a fundamental thing is to measure well-being indicators regularly and think about every government policy about how this would contribute to that, and are we improving over periods of a decade? So now we do have a framework. The Treasury put out a draft set of measures for the framework, and they called for public consultation. And initially they had sort of positive well-being, life satisfaction type measures in it, but they didn't have anything on mental ill health. I put in a submission, I think others did, and now they've got that in as well, because they're both important aspects.
Good for you. Yeah.
So I think that is really good, and I hope both sides of politics, I hope eventually they will, like having a Minister of Mental Health, they realise that this is really important framework to think about everything we're doing. So I think that is a really important positive. And, you know, I think also we've got to look at some of the big causative factors. Like that's where the physical health improvements have occurred. You know, smoking's the classic one, but you know, asbestos exposure and ultraviolet and all that sort of thing. And when you look at what are the big drivers of mental health problems, it's adverse childhood experiences are huge. We've had a lot of attention to things like, you know, sexual abuse and physical abuse, but a lot of people don't realise that actually emotional abuse of children, which is things like, you know, belittling the child or saying, you know, oh, wish I'd never had you and things like that, that is equally damaging to sexual and physical abuse. People don't realise that's equally as damaging. So there's a lot, you know, we could do on those sort of risk factors. There's some indication that it is improving gradually, but I think they're big drivers that we've got to try and push to get sort of long-term benefits. I think what we tended to do is to do things as we were alluding to about that you can evaluate in randomised controlled trials. So sort of psychological type things, psychological interventions, they're the easiest to do a randomised controlled trial. You go into a school, you train this group of kids and this group's the control. And so, you know, they're the best evidence. Whether they're the best solutions in the long term is another matter. So this is another disjointed thing, because you can't easily do randomised controlled trials on child abuse. But, you know, we introduce things like working with children checks and that sort of thing. You know, and presumably they may have a long-term effect. There's never going to be probably any randomised controlled trial evidence on something like that.
No, exactly. Look, it's like because I think, you know, we do a lot of psychological interventions in our work. We do a lot of, when we can, we try and do RCTs, but an element of it is knowing its limitations, you know, like it's a part of it is playing the game, because if you want to get funding, you need RCTs. If you want to demonstrate, you know, so there's this balancing act. And I wonder sometimes where researchers, they stray into the game side of it, you know, getting the metrics and getting the right studies so I can win the right grants. But keeping one foot in the community, which I think that's something that we do. I think we've probably modeled a lot of our stuff on the mental health first aid sort of framework of having a foot in community, a foot in the research world. I personally have felt like that's been a bit of a superpower for us to date. And you touched on so I didn't realize, I was just quickly having a last minute Google of your profile on the Uni Melbourne site. And I realized that you're involved in the Making Minds, a Growing Minds campaign. Is that
Growing Minds Australia, which is a clinical trials network for children and youth, mainly emphasising children,
Yes. So it's just, I didn't actually realise, and I made a couple of comments about it on the podcast recently, but I was sort of sitting on the couch and I saw the ad come up with my wife. And I was sort of saying, we had very different perspectives. She's a school teacher, and I was kind of looking at it like, man, this is a good campaign. The way they've designed it and the way that it's been applied, because often research things don't come out looking that interesting. It looked like, if we're talking about the right campaign as well, that's the other thing.
I think we're talking about something different. Growing Minds Australia is a clinical trials network. I'm not sure what campaign I'm
talking about. Mine might be called Make Minds Grow. Anyway, the point will be fine.
No, that's a different one.
Okay.
Very similar name, but different one. I don't know about.
So you're right. I think this was maybe even only in South Australia, but I was looking at it thinking, this is a nice campaign. It's been well executed. I was looking at it probably from that perspective. Her perspective was, because the message of the campaign is basically like, talk to your kids and give them attention.
Yeah,
and that didn't click to me at first. And obviously, she's a full-time mum at the moment, so that's very close to her mind. I guess I'm also obviously a full-time dad in a sense, but that did throw me into a bit of a tailspin. Like, we who are interested in prevention, if this is the type of messaging that we're needing to put out into the culture right now, almost what chance do we have is almost where that's where my mind went. This thing of if has something gone wrong in our society where we're having to sort of remind parents to talk to their kids and engage with their kids? And if so, we've got a mountain of work to be doing.
Yeah. Look, there are, extremes of parenting, like the child maltreatment, child abuse, very controlling and so on. But most parents aren't like that, but if they are, they're huge risk factors for mental health problems in the child throughout life. But then you got this sort of dimension, like you're dealing like, care and affection. Well, they're on a dimension, and when you measure that in the population, for example, you find that mothers are on average more affectionate than fathers towards their children. And I've thought, okay, well, what if we could just inch, and within both, right, the more affectionate, the more protective. Right. Within the mothers, it is, within the fathers. What if we could inch the fathers up just a little bit closer to the mothers? It's a small amount. Would that then have a protective effect of the whole population? So just sort of moving social norms a little bit. And there are other things you can think of, like it's known that conflict in the home is a risk factor. And, parents do have conflict. That's just inevitable. But if you knew that this is going to potentially damage your child's mental health throughout life, could you say, well, if we're going to disagree, we're not going to do it in front of the kids. We're not going to try and get them to take sides. We can just move everybody a little bit that way. Would that have, a protective effect on them? And you get things like alcohol, like parents do things like they're big suppliers of alcohol. They have alcohol available. They model it. They make jokes about people being drunk and it's funny, and I need a drink to relax. So they're all doing all these things. So if they could just ameliorate those sort of behaviours, could that then have a protective effect on alcohol abuse later on in the population? So at the individual level, they're all very minor for an individual family. But if you could do population shifts, could things occur?
So maybe I've misinterpreted, seeing this campaign, I thought, there must be this epidemic of sort of, distant parents or something like that. But actually what you're suggesting is potentially that campaign is there to just inch anyone.
I don't know why that campaign is there. I don't know that campaign, but I think that, you could have a rationale where you're not dealing with extremes of risk and protection factors, but shifts
Yeah.
in social norms and the distribution in the population that might have some positive effect. Yeah.
So then the last sort of, this probably ties in again, but your role in the new journal, Mental Health and Prevention.
Yeah.
Did you have a hand in sort of creating that journal, or are you're the first?
No, the journal existed. I didn't create it. The original editor died, and then it passed on to someone who was a younger person that worked with him, and then she, I think, found it a lot of work, and then they looked for a new editor. I had been thinking of founding a journal, because I think there is no prominent journal on prevention of mental health problems, promotion of positive mental health. And this journal was not a well-known journal, so they were advertising. Oh, right. Why start a new one when this one exists, and then try and redirect things? So then I applied and got the job. Now in my second term, coming up to 6 years as editor-in-chief in this time. So I've been trying to get up the quality of the work, and I think we are. I think we're getting better and better work at it. But to have a journal that does specialise in this area, because there really isn't any other, and we're trying to get special issues on big problems. Like we had one recently on what should a nation do to produce better mental health in the population. This is a huge problem, and ask people to take for their country or for the world as a whole or for a subgroup in a country. So, well, what should governments do? What should we all do to try and improve things? Big picture things of that sort. We're starting another one soon about the youth mental health has got worse in Australia and many other countries. So what are the causes, and more importantly, what can we do to address them? So the mobile phones is one of the hypotheses about that. But it has got worse. If we could find out what the causes are, rather than say we'll have more services, which is fine, and what should be done? What should governments do? What should schools do? What should parents do to address those? So try and focus on some of these huge problems where preventive action is needed.
Yeah. And so, I guess my question was sort of what is your hope in the direction of the journal? And it sounds like asking the biggest questions you can think of, basically.
I think it's the biggest questions would be the thing, and underpinning action. It's one thing to have a publication; it's all very nice, but it's a means to an end. So, and a lot of papers we reject because they look at some association between this and that mental health, and they say, well, someone ought to do something about it. But we want to know what should be done. We want to focus on the action rather than just say someone ought to at the end of an article. Practical action for prevention.
And so what were some of the responses for that special edition around what should nations do?
Oh, well, I've done an analysis of all the contributions and looking what the common elements are. There are quite a lot, there's obviously a lot of emphasis on early in life, like having good quality childcare, perinatal services to, treatment depression in mothers and parents in general is a big thing. Screening them for mental health problems. Having good childcare, to have school-based welfare programs like anti-bullying programs. There's a lot on, workplace programs, to reduce bullying, have conditions for positive mental health in workplaces. I could go on. There are a whole lot of things that were repeated themes that came out. So there's no one solution.
Yeah.
But we need to probably have sort of national plans where we look at all these potential contributing factors and try and begin taking action in a coordinated way. A national mental health prevention plan, promotion plan.
Yeah, and that's where I'd probably love just to wrap up the conversation on this topic, because I have 1,000 citations, you have 100 and something thousand citations. hope would be, so, yours is a career that anyone in the research world would aspire to. And I think part of the reason why you aspire to that is because at the end you say, well, I'm someone who could be trusted. I'm someone whose expertise could be useful in the world. So my hope, I guess, is that someone like yourself can be calling somebody in the country to say, actually, this is what we need, and that you would be listened to. Is that kind of is that naive of me? Is that kind of how it works? Are there things in the works for something like what you're describing?
There are influential people in the mental health sector, that's for sure, and I'm certainly not one of them, unfortunately. And some of the advice I think that's given is probably not optimal for the country.
Yeah,
I think we've had a lot of expenditure that's in the interests of people in the mental health sector, but not necessarily in the interests of the mental health of Australians. So, I think it's going to be a long-term thing. I know the conference you alluded to that you and I went with, Prevention United, which Steve Carbone founded that, and he's done a tremendous job of trying to get everybody cooperating and get a national action on prevention. So we do need agencies like that because, individual academics, we can, Prevention United can draw on what we're doing, but that sort of coordinated action, because ultimately when you go talk to, I do talk to politicians sometimes, but when you do, it's how many voters do you represent?
Yeah.
And can you give a solution that's going to be applicable within the time frame of the government, which are big challenges, but that's something that's got to be worked within. But I'm seeing in the sector now much more attunement to issues of prevention. Like I noticed Mental Health Australia, which is the peak body in the area. I used to be on their board years ago when it first started, and it was very much concerned at that time with specialist mental health services. And now I think they're commenting on things like poverty and unemployment. Like they're not looking at mental health services per se, they are, but they're also looking at things. Well, okay, if people on various social welfare don't have enough money, that is a big risk factor. If the unemployment rate goes up, that is a big risk factor. If parents have difficulty caring for their children, that's a big. So they're looking at all these broader factors. So that's a big change of perspective as well, which I think is needed.
Yeah. How much does that get in the way, in a sense? Like, I wonder, not get in the way, but when you look at the world through that lens, it's almost impossible to draw the line on what is mental health and what isn't. And so someone like Mental Health Australia almost could find themselves thinking, we basically have to solve, we have to address every social determinant before we can see improvements in mental health. And that might be true, but how is it possible for someone to be for an organization to be addressing that?
Well, that's true. It's not simple. It's a step at a time. But this is what I think these wellbeing frameworks are so important, because you're absolutely right that if you say, well, this is what the nation is about, these are our aims, these are our indicators of whether we're doing well. And it's not all about the health budget. And people are beginning to realise that. There are budgets right across all those government departments that potentially affect those indicators, that are potentially about mental health. To see it as much broader as a whole of government aim. So I don't see it as just a health issue. I see it as what our aims are as society. There's we want positive well-being, the sort of things that you have great interest in, and we want to have reduced mental health problems, mental disorders, as the other component. And both of those, I think, have become major foci for us as a society.
Yeah, absolutely. Well, thank you so much for your time, Tony. This has been honestly a very an honour to have you on.
I've really enjoyed the conversation with you, because
I appreciate it.
It's been a great discussion. Yeah.
Thank you. And so anything that we've missed that you'd like to cover? Any places people can find you, or anything to plug?
No, I can't think of anything off the top of my head. If you want to be in contact with me, Google, my email address is there, and you can send me a message. I'll happily correspond with you.
Fantastic. Well, thank you so much. And again, I really appreciate it.
A pleasure.